Welcome! Let's dive right into acute rhinosinusitis. This is a topic that's almost guaranteed to pop up on your PBC exam, so we're going to break down everything you need to know from diagnosis all the way to treatment. My goal is to get you feeling really confident about handling this common condition.
So here's how we'll tackle it. We're going to walk through 5 key areas. We'll start with nailing the diagnosis, then jump into symptom management and smart antibiotic choices. From there, we'll cover what to do when things don't go as planned, and wrap up with the tricky stuff, caring for special populations.
All right, first things first. Before we can even think about treatment, we have to be absolutely sure we know what we're looking at. So what exactly is acute rhinosinusitis, and how do we spot it? Okay, so the official definition is pretty simple. It's an inflammation of the sinuses and nasal cavity that lasts 4 weeks or less. But here's the key thing, the part you really need to remember for your practice. While patients might come in asking for antibiotics right away, the vast majority of these cases start out as a simple viral cold. Now, to help you remember the main symptoms, there's a great little mnemonic. PODS, you're looking for P for facial pain or pressure, O for nasal obstruction, D for purulent discharge, and S for a disorder of smell. Either it's reduced or gone completely. If a patient checks these boxes, rhinosinusitis should be at the top of your list.
This algorithm, right here, is basically your roadmap. It pulls everything together and shows you the step-by-step thinking. Let's really zero in on the most important decision points, starting with the biggest question of them all.
And here it is, the #1 challenge you're going to face. Is this thing viral or is it bacterial? So many people think the color of the nasal discharge tells the story. Well, it doesn't. The real clue, the thing that gives it away, is all about the timing and the pattern of the symptoms. You can see the difference so clearly right here. A viral infection, it usually gets bad and then gets better, all within about 10 days. We only start thinking, maybe this is bacterial in 2 very specific scenarios. 1, the symptoms drag on for more than 10 days and just aren't getting any better. Or 2, the patient starts to feel better and then bam, they get sick all over again. We call that double sickening. Now, before we go any further, we absolutely must talk about red flags. These symptoms are screaming that the infection might have spread beyond the sinuses. If a patient shows up with any of these, like they seem confused, have a killer headache, or any changes in their vision, this is a medical emergency. They need to be referred and fast. So, we've ruled out the scary stuff, and we have our diagnosis. What are we trying to achieve? Well, it's not just about throwing drugs at the problem. It's about making the patient comfortable and being smart with our prescriptions. That's why managing symptoms is always our first move. We've really got 4 main goals. Of course, we want to make the patient feel better and get rid of any infection. But just as important, we're trying to stop this from happening again. And this is a big one. We need to cut down on unnecessary antibiotic use. That's key for fighting antimicrobial resistance. This table lays out our whole initial toolkit. You always start with the non-drug stuff: saline rinses, rest, hydration. For pain, simple analgesics like acetaminophen or ibuprofen are great. Now, the 2 things to really pay attention to are decongestants and intranasal corticosteroids. The topical decongestants, only for 3 to 5 days max, or you risk rebound congestion. And high-dose nasal steroids, they can offer some real benefit and maybe even help you avoid antibiotics altogether. Okay, let's get to the heart of the matter for us as pharmacists. When do we actually pull the trigger on antibiotics? And when we do, which ones should we be reaching for based on solid evidence? This single number tells you almost everything you need to know. The number needed to treat is 19. Let that sink in. You have to treat 19 patients with antibiotics for just 1 of them to actually benefit. Meanwhile, the number needed to harm is only 8. That huge gap is precisely why our default strategy should be watchful waiting. So when we finally decide an antibiotic is needed, based on those timing rules we talked about, amoxicillin is the clear, undisputed champion. It works great against the most common bugs, Strep pneumoniae. It's narrow spectrum, it's less likely to cause resistance, it's pretty well tolerated, and it's cheap. This is a huge exam point, folks. Knowing what to use is half the battle. Knowing what not to use is just as important. You'll see macrolides like azithromycin prescribed all the time, but it's a mistake. They are not recommended. Why? Because the main bacteria we're targeting, S. pneumonia, has developed a ton of resistance to them. It happens, right? Some patients just don't get better with that first antibiotic. So what's our next move? What does the evidence tell us to do when first-line therapy fails? First off, we need a solid definition of failure. It's not just a patient feeling a little off. We're talking about a clear lack of improvement after a full week of antibiotics, getting worse during treatment, or having the infection come right back within 3 months. So, if amoxicillin doesn't work, our go-to is amoxicillin/clavulanate. The logic here is simple. The most likely reason the first antibiotic failed is because the bacteria is producing something called beta-lactamase, an enzyme that just chews up amoxicillin. Well, clavulanate is a beta-lactamase inhibitor. It acts like a bodyguard, protecting the amoxicillin so it can do its job. And this brings us to a major safety alert. Fluoroquinolones, think levofloxacin, are the absolute last resort. Health Canada and the FDA have put out serious warnings about their risks for some really nasty, sometimes permanent side effects. For an infection that's usually not that serious, like rhinosinusitis, the risks of using these drugs almost always outweigh any benefit. All right, let's wrap up by talking about two special groups you will definitely be tested on: patients who are pregnant or breastfeeding. The overall game plan is similar, but we have to be extra careful with our medication choices. In pregnancy, we're very conservative. Acetaminophen is your go-to for pain, especially after 20 weeks when you have to avoid NSAIDs. If an antibiotic is truly needed, guess what? Good old amoxicillin is still the top choice. And it's just as important to know what to avoid. Drugs like doxycycline, fluoroquinolones, and SMX/TMP are all big no-nos for very specific safety reasons. For breastfeeding moms, the story is pretty similar. We'd much rather use a topical decongestant than an oral one, just to minimize how much gets to the baby. Amoxicillin and amoxicillin/clavulanate are both considered safe. The really important counseling point here is to tell the mom to keep an eye on her baby for any side effects, like diarrhea or a rash. And here's a huge clinical pearl. File this one away for the exam. While some oral decongestants might be okay, pseudoephedrine is special. It has actually been reported to reduce milk supply. Now, that is a critical piece of information to share, especially with a mom who might already be worried about her production. So, what's the big takeaway from all this? It really boils down to antibiotic stewardship. It means trusting the clock, focusing on symptom relief first, and only using those narrow-spectrum antibiotics when they are truly needed. And this leaves us with a pretty big question for the future of pharmacy. As these bugs get smarter and resistance gets worse, how are we going to have to change our approach to these incredibly common infections?